So I'm going to talk to you today about neuro-ophthalmology. This is again a very important topic and quite complex in its own way. So I'm going to try and make it simple. I'm going to cover only a few common conditions relevant to your practice, also relevant to the examination, as some of these topics will be definitely asked of you in both the theory and you could get this in the practice. So I'm going to talk now about localization in neurology. Neurology is a very mathematical science in which it is possible by history and clinical examination to almost precisely localize what the problem is in almost 90% of patients. And these principles that I'm going to teach you would be useful to you no matter what specialization you go into, and I've tried to simplify this in a manner that would be easy for you to remember. Now, whenever we approach a problem in neurology, there are three maxims that we need to remember. This is after teachings of a very senior neurologist who outlined this in this manner. The first thing we need to define is there a problem? Because we do get a lot of patients with functional problems to us, and so it's important to know whether there is genuinely a problem, or is this something which is on the borderlands of functional medicine, or is this something that is nothing to do with neurology. If we define that there is a problem, the next is to localize it as to which part of the brain or the spinal cord or the peripheral nervous system, where is this problem located. And this is all about localization. And for this, it will be important to have an idea about the principles of the neuroaxis and the principles of localization, which is what this talk is about. And finally, what is the problem? This is perhaps the easy part, because once you define where the lesion is sitting, then of course there are only a few broad groups of issues where you can place the problem, whether it is metabolic, whether it's inflammatory, whether it's infective, whether it is degenerative, whether it's inherited, whether it's traumatic, whether it's vascular, and you will be able to place it. Now, I'm not going to go into history taking, which most of you would now be comfortable with, and over a period of time, once you decide on your branches of specialization, you'll further learn to take specific histories. Needless to say that it's important that to basically take a very good and detailed history, identify A, if there is a problem, and B, what the cardinal symptoms are, and then do a quick neuro examination again, which is fairly standardized. And at the moment, since we're mostly focusing on theory at the moment, this is I will not go into neuro examination at this moment in time. So the nervous system is divided into the brain and spinal cord and the peripheral nervous system. The CNS is basically the brain and spinal cord, and the peripheral nervous system is basically anything outside that, which is basically the nerve roots, the nerves, the neuromuscular junction, and the muscle, and also includes the autonomic nervous system, which is a fairly independent entity by itself, but comes under the coverage of the peripheral nervous system and the cranial nerves. Now, there are two or three systems which basically run our nervous system. One is the motor system, which you're all aware of. It consists of the corticospinal tract, which starts from the motor cortex and ends on the spinal cord. It basically is involved in our skilled, our intricate, our delicate movements, which require dexterity and organization. And if there's a lesion to this, it will lead to a loss of voluntary movement. So there will be motor weakness. It will cause spasticity and changes in the reflexes. Then we have the extrapyramidal system, which basically refines the motor system. If the extrapyramidal system was not there, it would be a lot more clumsier, and it allows our movements to be fast and fluid, and which have been basically generated from the corticospinal tract. And if there are lesions in the extrapyramidal system, you have to only imagine a case with Parkinson's disease, for instance, and you think of bradykinesia, rigidity, tremor, involuntary movements, and instability. Now, the cerebellum likewise also provides mostly our balance, and it's the two cerebellar hemispheres with the interconnections coordinate smooth and learn movements initiated again by the pyramidal system. So in a way, the cerebellum and the extrapyramidal system, they support the corticospinal tract, or the pyramidal system. It's called the pyramidal system because the cells from where the motor fibers originated were called the pyramidal cells, but mainly because of their shape, and hence it's traditionally called the pyramidal system. And basically posture and balance control, and to some extent even refining our gait, comes from the cerebellum. So if this was there was a problem in the cerebellum, and there would be ataxia, there would be tremors, incoordination, and also to some extent we would have dysarthria and other symptoms which would indicate cerebellar disease. Now, it would be important to know about the upper and lower motor neuron signs. I think this is something we've all learned from our very basic medicine days. It would be enough to say that the upper motor neuron starts from the level of the brain right up to the spinal cord, and anything beyond that is the lower motor neuron. So weakness is a common feature in upper motor neuron lesions. It's also present in lower motor neuron lesions, but the weakness in the lower motor neuron lesions would be a little fairly marked. The wasting is more present in lower motor neuron lesions, as is fasciculations. Reflexes are very brisk in upper motor neuron lesions. In lower motor neuron lesions, they could be occasionally normal depending on the location of the lesion, or they are reduced. Clonus is present in upper motor neuron lesions, whereas plantars are upgoing in upper motor neuron lesions and downgoing in the lower motor neuron lesions. Now, likewise, like the motor system, there's a sensory system which comes out from our peripheries into the center, and it carries sensation from the dorsal roots to the spinal cord. From the spinal cord, it ascends in two tracks: the posterior columns, which carry a vibration, joint position, sense, and a part of the touch, and cross in the brainstem, passing to the thalamus, which is the main relay station for all the sensory input. There's a second set of fibers carrying the pain, temperature, and part of touch, and they also cross within the cord and pass in the spinothalamic tract to the thalamus. And from there, the impulses are taken to the sensory cortex in the parietal lobe and its association areas from the thalamus, where the sensations are red. The brain has four major lobes. We're all aware of that. It's good to have a quick run through and revise these. The frontal lobe is mainly involved in reasoning and planning, sequencing, movement, and also is a seat of our emotions. And our frontal lobe sets us apart from the other animals. And the frontal lobe is most developed in human brains, but chimpanzees are the next closest to us, having a large frontal lobe. Frontal lobe lesions generally will cause motor weakness and aphasia, and of course in long-term degenerative conditions like frontotemporal dementias and Alzheimer's, there is loss of lobe function as well. The parietal lobe mainly is involved in movement and recognition of sensory stimuli, and occipital lobe in the occipital lobe is mainly in visual processing. The temporal lobe looks after perception and recognition of auditory stimuli. It stores memory, and also has part of the receptive speech area where the sensory part of speech is read, the motor speech being in the frontal lobe. The cerebellum, as mentioned, is involved in balance and coordination, and the basal ganglia in initiation and smoothing of your movements. And these basically all function with interconnections with each other to help us function. Now, the spinal cord basically is a relay tract which takes the sensations up to the brain, and likewise motor sensations pass through to help us to ambulate, move, sense, feel, and function. Of course, there are many lesions that can affect the spinal cord, but a spinal cord lesion will have three cardinal features: basically weakness, depending on the level. If it's a high cord lesion, it can cause quadriparesis; a low cord lesion, paraparesis, with a clear-cut sensory level, because the sensory tracts are interrupted, and because all the bladder fibers and sphincter fibers are in the spinal cord, there's involvement of the bladder when a cord lesion takes place. Now, the two parts of the spinal cord are extremely important. One is the corda equina, which basically is involved with sensory and motor function in the legs, the bladder, and bowel function. And common lesions usually are either a herniated disc or any disseminated metastasis. And basically, this scattered pain and weakness of leg, loss of reflexes, and sphincter involvement. And corda equina lesions should be recognized, and immediately the patient needs to be rushed to the neurosurgeons. On the other hand, the lowest part of the spinal cord is called the conus, which again has been involved in both motor sensory functions and sphincter involvement. And again, it's involved by usually disc lesions, and it causes weakness in legs, loss of reflexes, and again, sphincter dysfunction, and is a fairly rare involvement. Now, is a very rare involvement as far as lesions go. Now, it's extremely important to understand the concept of the neuroaxis. The neuroaxis is not just horizontal or vertical. It does function on both these planes. So starting from the brain, the cortical brain, to the subcortex, the brainstem, which is the seat of most of the cranial nerve nuclei, and some of the vital functions of our body are governed from there. It passes on to the spinal cord, but just before that, the cerebellum sits on either side, which inputs into our motor system mainly. And then from the spinal cord come out the roots. The roots go on to form plexuses. The plexuses then lead to peripheral nerves. From the peripheral nerves, there's a neuromuscular junction, and then there is a muscle. Also within the spinal cord, of course, is the anterior horn cell. Now, this basically forms the neuroaxis. So you have to think of the neuroaxis just not on one vertical axis, but also spreading somewhat horizontally as well. And each has a distinct constellation of signs, symptoms, and we must be aware of them because this helps us to localize lesions. So how do we examine the neuroaxis? Well, there are certain tests which are specific for certain parts of the neuroaxis. So if you do higher cortical functions and we look for aphasia, agnosias, and apraxia, this will help us to determine higher cortical function. Whereas if we examine the cranial nerves, because most of the nuclei are sitting in the brainstem, this gives us an idea about brainstem function. Of course, the pyramidal tract also passes there, and so it's a constellation of symptoms. But cranial nerves help us to localize to various parts of the brainstem. Cerebellar function is assesses the cerebellum distinctly, whereas the motor system, if you examine, starts from the motor homunculus, which is the part of the motor cortex, where there's a representation of the human body, to the subcortical brain, where the pyramidal tracts pass to the brainstem, the spinal cord, the roots, the peripheral nerve, and the muscle. All of them basically form a part of the motor system. The sensory system is on the opposite side. It starts from the peripheral receptors to the sensory nerves, to the spinal cord, to the thalamus, to the subcortical tracts, to the sensory homunculus, where the human body is represented in the sensory cortex. And then, of course, the deep tenon jerks, when we elicit them, they're a bridge between the motor and sensory functions, because the reflexes are sensed, and then there's a reflex arc in which the motor system acts to provide the reflex to us. Now, we'll go step by step through each part of the neuroaxis to define, and the subheadings in each will be the same. So it becomes easier for you to remember, and you would be able to localize lesions. If you remember these and keep them in your mind, you will be able to localize a lesion at any time. So if there's a lesion in the sensory cortex, we could get aphasias, depending on where it's located, either a Broca's or a Wernicke's aphasia, or a mixed aphasia if it's a very large lesion, like a large stroke. Apraxia generally indicates a parietal lobe issue or an agnosia. So these, if they're present with, say, motor weakness. So if you get aphasia and motor weakness, you would immediately localize it to the speech area, and of course the motor tract is involved, like say an MCA territory infarction, and you would know that this is higher cortical. Now, the cranial nerves will be normal because the cranial nerve nuclei are not there. The cerebellar function will be normal. Motor, of course, there'll be weakness if you hit the motor homunculus. The sensory, if the sensory homunculus is involved, then it'll be involved. The tenon jerks will be brisk, and you could get a upgoing planters, so that would indicate indicate a cortical lesion. In a subcortical lesion, the higher cortical functions would be normal, but there would be problems in the visual fields because the optic pathway passes through the subcortical region. The cerebellum will be normal. There would be involvement of the motor system. So if it's a subcortical lesion and the motor tracts are involved, there would be likewise there'd be sensory involvement. There would be wrist reflexes and an upgoing plantar. Now coming to the brainstem. When you in the brainstem, again, high mental function should be all right, but you'll have involvement of cranial nerves. So if the third and fourth nerve are involved, it usually indicates that we are sitting somewhere in the midbrain. If the sixth and seventh nerve are involved, it will be the pons. And if they're the lower cranial nerves, which is the 9th, 10th, 11th, and 12th nerves, this indicates a lesion in the medulla. So if you're able to pick up these cranial nerve lesions, you can immediately pinpoint where the problem is. The cerebellar function usually should be all right. The motor system would be obviously affected because it passes through the brainstem unless it's a very lateral lesion. If it's a very medial lesion, and so you would get hemiparesis and upper motor neuron signs. Likewise, you could have sensory involvement. There'll be hyperreflexia and the positive plantars. The difference between cortical brain here and brainstem lesion is that there'll be no involvement of higher cortical functions. And in the subcortical brain and brainstem is that here the cranial nerves are involved, which would then indicate to us where the problem is. Going a little now horizontally, we go on to the cerebellum, in which generally all the functions are okay, but they get clear-cut cerebellar signs, and generally you could get nystagmus, you could get dysarthria, a staccato speech or a scanning speech, and you could get incoordination, and you could get some tremors in the motor system, and the classical signs of pass pointing, finger-nose incoordination, and impaired tandem walking would be elicitable. Sensory system would be normal. Reflexes are generally normal, and there's no pathological reflexes. There are some reflexes described in cerebellar lesions as well, but I won't go there. And for broad purposes, I think this is important to remember it like that. Now, I explained to you that going a little lower down, next comes the spinal cord in the neuroaxis, and when you have a spinal cord lesion, there generally is a sensory level because it's transected, and so the sensations below the level of lesion would be affected. And there'll be weakness before the level of the lesion. If it's a lower spinal lesion, paraplegia. If it's high spinal lesion, quadriplegia. There'll be upper motor neuron signs below the lesion, and there would be sphincter involvement. And when you get this constellation, always localized to the spinal cord. So high mental functions, high cortical functions normal, cranial nerves normal, cerebellar function normal, no other issues. Motor system below the level of lesion is affected, sensory system below the level of the lesion is affected, and tendon jerks are brisk below, and Babinski will be up. Now roots come out of the spinal cord, and now we've started in the low motor neuron part. So these are LMN lesions. They will produce asymmetric weakness in that root that is in that root distribution. So the muscle supplied by that root will be weak, and that group of muscles supplied by a nerve root is called a myotome. Sensory pain and dysesthesia is in the nerve root distribution. So if you have, say, the thumb and the index finger involved, you know that it's a C5-6 lesion. There could be weakness of pinch grip, and there could be loss of sensation or paresthesias in that distribution. Reflexes are hypo or areflexic depending on the nerve. So we know the root value of all our reflexes. C5-6 is the brachial and the brachioradialis, and the triceps is C7. And so on and so forth. So if you know the root value of our reflexes and the reflex is absent, the rest of the reflexes will be normal. You know that this is a root lesion. Neuromuscular junction, think of myasthenia gravis immediately. So high mental function normal. Cranial nerves, you know that it's mainly the oculomotor nerves that are involved. So there will be ptosis, there'll be problems in gaze, and sometimes there can be jaw weakness. The cerebellum is normal. The motor system generally is normal unless there's fatigable weakness and a generalized myasthenia. But sensory, reflexes, pathological reflexes all are normal. There's no pathological reflexes seen. Now, from neuromuscular junction, we also look at peripheral nerve. The peripheral nerve basically is mostly a distal weakness, and there is loss of sensations in a glove and stocking distribution unless it's a different pattern of nerve involvement, like a mononeuritis multiplex. So refer to my talk on peripheral neuropathy. But reflexes are lost. Areflexia is common because obviously when you tap a reflex, the sensory system will not be carrying this impulse to the motor system, and there'll be no pathological reflexes. So mainly a distal weakness with loss of reflexes indicates peripheral nerve. Whereas on a muscle, it's you can have a cranial nerve involvement sometimes, but most of the time muscle will cause a proximal weakness like a muscle dystrophy, and you would find it difficult for getting up from a lying, sitting, from a lying or a squatting position mostly. Gauss sign, which is climbing on yourself, could be positive. Sensory is normal, reflex is normal, and no pathological reflexes. So muscles basically cause a proximal weakness, nerves cause a distal weakness, and neuromuscular junction will only involve the oculomotor muscles and bulbomotor.